I am very excited and honored today to have with me Dr. Margaret Kirkegarrd, and we're going to be discussing, access to care and what that might look like, what some of the answers might be. If we had the answers, maybe we wouldn't be having this conversation right now. And so I'd like to welcome Dr. Kirkegarrd, and thank you so much for finding time out of what I know is a very, very busy schedule. And thank you for joining us today.
Well, thank you for having me. I'm delighted to be here and to be able to talk with you and your members about this very important issue regarding access to care.
Well, thank you. So, why don't we just jump right in? It's always important to me that everybody kind of have an idea, who are you and why are you somebody that I feel is impactful for this conversation? So if you don't mind, let it rip. What's your background and why are we having this conversation today?
Well, thank you for inviting me to speak with you. And I'm a family doctor by my clinical background. I'm actually a third generation family doctor in my family. So my grandpa and his brother actually ran a small hospital in rural Minnesota. So I kind of grew up with that background and environment. And I always thought that I would go into very traditional family medicine, which I did do. I went to medical school and residency training and went into practice. But after being in practice for about a decade, I realized that so many things that I needed to do, that my patients needed to be well, to actually have wellness and well-being, depended on the healthcare delivery system. I could be the most brilliant doctor in the exam room and give them compassionate, great medical care. But if they left the exam room and they didn't have the health insurance or the access or transportation or all the other components needed to actually get health care and achieve well-being, then everything I did in the exam room didn't matter. So I actually decided to go back to school. I left my practice, which made me feel very sad to leave patients that I had grown to love. But I felt like I needed to be equipped both inside the exam room, but outside the exam room. What happens in our healthcare delivery system? So I went back to school, got a degree in public health, focused my studies primarily on quality improvement and access to care issues, especially for underserved populations. And since that time, I've spent most of my professional work looking at the interface between medical care and how healthcare is delivered in the United States. I still do some clinical care and I teach in a family medicine residency program, and that keeps me very grounded so that I'm still see patients and I understand the needs of patients, but at the same time, I really can focus on what is happening upstream. So when patients leave the exam room, I understand how to be more effective in helping them actually access the healthcare that they need.
We talk about and we hear about over and over and over again about the underserved community. How would you define underserved community?
Oh, that's a good question, Anne, because it has so many different definitions. I think traditionally in the United States, we think of people as underserved as those people who don't have health insurance. We are the only industrialized country in the world that doesn't have universal health care. And historically, we've had high rates of people who don't have health insurance. Right now, we have about 10% of our population does not have health insurance in the United States. So that's the sort of traditional historical definition of underserved. But I think we should be very clear that people can be underserved for a variety of reasons. So the mantra that's emerged in the last decade on healthcare is access to the right care at the right time in the right place. So if I have a cold, I don't need to go to the emergency room, or I shouldn't need to go to the emergency room to get care. And so we need the right care at the right time in the right place. So people who don't get the combination of those three things could, in fact, be underserved. And if you look at other barriers to care, for example, rural patients, we're seeing the emergence of many maternity deserts where people don't have access to maternity care. we're discovering that, or not discovering, we're learning that many people who should have health care at home, it's very difficult for many elderly patients to, or disabled people with disabilities to go to a doctor or a hospital to receive care, where they could, the right place for them might be to receive care in their home environment. So really, anybody who doesn't receive care in the right place, the right time, the right care in the right place, the right time, really is underserved.
So how many people fall into the underserved community, or is that just too broad of a number to even be able to specify?
So as I said, many people can be underserved for many reasons. Maybe there's language or cultural barriers. Maybe they live in a rural community, or they're elderly or disabled and they don't have the mobility or the transportation available. But I do think it's important to focus for a minute on our traditional definition of underserved, which is people who don't have access to health insurance, generally because they're poor or because they can't afford that health insurance. And in the United States, there's still 28 million people who lack health insurance. We know that the ACA made great strides in improving access to health insurance in the United States. The ACA basically did three things. It offered some modifications of our traditional health insurance system, which is primarily employer-based in the United States, but it created some additional expansion of that, things such as allowing young adults up to age 26 to remain on their parents' insurance. So we know that a few million young adults were able to access health insurance through that mechanism. The second thing that it did is it created the health insurance exchanges, where people who have lower incomes are able to purchase health insurance and receive tax subsidies in order to purchase their health insurance at a reasonable cost. So the ACA set up those health insurance exchanges, or the marketplace. So that was the second thing the ACA did. And then the third thing the ACA did was to expand Medicaid. So we've had Medicaid in the United States since 1965, and Medicaid was a program that was designed to help the disabled, children, and elderly who didn't have access to health insurance. However, prior to the ACA, if you were poor, but you didn't fall into some other category, for example, being pregnant or being a child, you couldn't be on Medicaid. And what the ACA did is it said poverty in and of itself is a qualifying factor for Medicaid. However, that section of the ACA was made optional for states. So we still have 13 states in the United States who have not expanded Medicaid, meaning if you're poor, if you work at a low income job and your job doesn't offer health insurance and you can't afford health insurance, you still won't be able to qualify for Medicaid in those 13 states. I think the other definitions of being underserved, for example, being rural or elderly, those definitions are broad and they may fluctuate over time. So you may be underserved during your pregnancy because you don't have access to sophisticated maternal fetal medicine specialty care, whereas during the rest of your lifetime, you may have access to care. So I think the way we conceptualize underserved may change throughout the course of a person's circumstances.
Thank you for watching the Lowdown on Cancer presented by the Cancer Fund. To learn more about what's coming in future episodes, visit us at www.cancerfund.com. While you're there, check out past episodes and be sure to click Join Us to become a member of the Cancer Fund community. As a member of the community, you'll receive early access to new interviews as well as other announcements. Make sure to connect to all of our social media channels so you don't miss a thing. In addition to getting early access to new episodes of the Lowdown on Cancer, Cancer Fund members play a critical role in driving cancer innovation forward so that one day we can more than hope. We can actually beat cancer. Thank you for joining us on this journey.